This is a Renew original recording. Hello and welcome to the Believe in People podcast. My name is Matthew Butler and I'm your host, or as I like to say, your facilitator. Today we have a returning guest in Grand Dame Carol Black, a trailblazing figure awarded the rare Dame Grand Cross for her relentless dedication to combating drug misuse in the UK. As the first female doctor to receive this honour, Dame Carol's impact is unparalleled. Her groundbreaking reviews on drug abuse have not only secured the record government funding but also sparked vital conversations on tackling drug-related challenges. Join us as we delve into her remarkable journey on advocacy and transformation. First of all, would you like to introduce yourself?
Yes, I'm Carol Black. I wrote the independent review for the government on drugs, and now I'm the independent advisor on combating drug misuse.
Thank you so much for coming on again to the Believe in People podcast. We don't get many returning participants. I think maybe the second returning participant we have, possibly the third. But a lot has happened since we last spoke to you, and we have to thank you because when we did our first podcast with you, that did help us get some eyes on the podcast and the local story, and it was the podcast where the local authority and the council actually really took notice of what we was doing, and everyone was very interested in what you have to say. So we got some really good feedback on it, so we've been really keen to do another one since. So last time we spoke to you, it was a few months after the publication of part 2 of your report, and here we are nearly 18 months later. Can you perhaps give us an update on the landscape since publication, highlighting any positives that you've seen since changes have started to be made?
Well, a huge amount has happened since my publication, because after that, of course, we had to secure, or with it, we got the money from government, and then the new 10-year strategy. And it is important to say this is a journey. It's not a 1-year journey, it's a 10-year journey. And that was December 2021. And then we had all the business of setting up the local arrangements, you know, the new combating drug partnerships, the senior responsible officer, the person who in each locality was going to chair that, the bringing together of all the different organisations that might be able to help us deliver the whole system approach, which is quite different from what we had before, which was really, by the time I wrote the review, we really had a treatment service that was not much more than opioid substitution therapy, quite frankly. So little money had been put into drugs recovery and treatment. It was really in a very poor state. So I guess the honest truth is we're climbing a mountain. It's not, you can't just snap your fingers and do this quickly. So there was all the practical stuff of putting in, if you like, the structure, the framework, the processes. And then there was the real and serious problem of the workforce. Because, you know, a lot of people had left the service, a lot of expertise had gone. So that has been, I think, for most providers, a big challenge, because we're no longer just looking for more drug workers. I do not want more of the same. I didn't write the report to have more of the same. I wrote the report to have change. So, you know, we need more psychologists, we need more psychosocial interventions, we need people who are expert on getting people into work, we need expertise on housing and how to help people find housing, we need real recovery programs. These all need people to deliver them. So I think the big thing to say is we're at the beginning of the journey. Yes, I've seen some places where they really understand what is needed and they're actually going about it, shall I say, in the way I wrote the report. And they've understood the importance of mental health and trauma. They know they have got to have proper recovery program. They may use one of the lived experience groups, you know, the LEROs. They may do it differently. And they're trying very hard to bring people together, including the police, the criminal justice system, social care. They understand collaborative working. Then I've seen places that are just doing more of the same. And that, of course, is disappointing. And we need to help them to understand that that's not what is going to bring about a change. It won't reduce the deaths. it won't get us more people in treatment, and it won't reduce crime. So I think it's a mixed picture, but there's definitely areas where they've really understood it. And they're getting on with it.
Speaking statistically, I can't say too much in terms of what we're doing, but I've definitely noticed changes on a day-to-day sort of perspective for us here in Hull. Last time we was at your home, once we finished the podcast, we spoke a little bit about individual placement support. We never had that in Hull at the time, and now we have a team of 3 people working on it, and they've had some really nice success stories as well that we've seen. I think one of the problems that they're having is getting recovery coordinators who are doing the day-to-day. We're fighting that uphill battle of having a caseload of 80 plus people to invest in individual placement support. What would you say to those key workers about the importance of getting people involved in IPS?
Well, the first thing I would say, having 80 clients is rubbish. You can't do it. You can't do proper treatment and recovery. There's something wrong with the commissioner. There's something wrong with the commissioning process that permits a provider to have only one worker to 80 people. So, I think that's an impossible task. But I think it is also, in my humble opinion, the responsibility of both the commissioner and the provider to ensure that the people working for them understand that part of recovery is having something meaningful to do. And for many people, that is work, paid work. It might not always be paid work. It might be volunteering to start with. You may need to have to upskill someone. But the value of a paid job to someone who's had no self-confidence, who really hasn't got many personal assets, it's invaluable in helping recovery. But you shouldn't really have more than 40 individuals to one drug worker.
I think that's one of the biggest problems that we found is just caseloads being unmanageable. And there are differences. I spoke to a colleague of mine called Jamie who works in the Making Every Adult Matter team, the meme team, and he has 15 people on his caseload. And I said, how was that? And he said, well, it's definitely manageable. But even though 15 sounds like a low number, these are 15 very complex people. And that's why they have the meme offer. So even then, he said, it might sound like a low number, but he said it's still journey, still is very complex. But speaking to a key worker who has between 70 and 80 people on the books, they're looking at him thinking, oh, you've got it easy. And it's obviously it's two really different things they're working with.
But even, however easy, no person who's taking hardline drugs is necessarily without challenges and without problems. They need time, they need input, they don't need a methadone script alone.
No, absolutely. For individuals currently struggling with addiction and mental health challenges, it can obviously feel like an uphill battle. From your extensive experience and understanding of these issues, what message of hope and support would you like to convey to them? And what resources or strategies do you believe can make a meaningful difference in their journey towards recovery?
Well, I think, first of all, what I've been trying to do is to get the message out there loud and clear everywhere I go, that mental health and trauma is part of addiction. It is not a separate thing over here, and that you will only treat somebody's mental health problems when they've stopped taking whatever is their drug of choice. They wouldn't be taking the drug, probably, if it wasn't for the trauma and their mental health issues. So we have a whole cultural change that's quite difficult because professionals have brought about that divide, not the people who are drug dependent. It is the way we have delivered these services that we've separated them out. And you would never say, let's say if you had prostate cancer and let's say rheumatoid arthritis, no one would dare say to you, well, when you've got your prostate cancer under control, we're going to treat your rheumatoid. You might be really crippled by then. We're not allowed to do that.
Of course, yeah.
So why are we allowed to separate these two? So the first thing is the message has to be changed. And then what we're really asking local authorities to do is to think about how are they going to co-commission mental health. and drug recovery and treatment. Now, some of them will say this is almost impossible to do, but if you look at Staffordshire has done it. They have joined their resources. They've got through all the difficulties of protocols, procedures, bringing budgets close together, sharing back office functions. They actually deliver their mental health and trauma support and their treatment and recovery as a whole package. You don't have to go to two places. So, I mean, that's the ideal.
Yeah.
And in the meantime, we just have to do it, I fear, almost authority by authority, finding out what their challenges are. Absolutely saying you're not going to get good results until you deal with mental health and trauma. And there's a big push in the Department of Health. There's a big piece of work going on between NHS England, which of course delivers mental health services, and OHID, which is responsible for the treatment and recovery. A big piece of work on mental health, seeing how do we really sort this out and bring it together in a considered way. So it may seem like a very small success, but talking therapies, as you probably know, very few people with addiction have been able to get talking therapies because the people who deliver the talking therapies say, oh, no, we won't be able to work with you because you've got a drug problem.
Yes.
Theoretically, and in all their regulations, they're not supposed to do that. And we've now met very much right at the centre with the top of the people in talking therapies. And that will gradually change. Won't change quickly. We will have to help people who deliver talking therapies to understand a bit more about addiction. And those people who are treating addiction need to be able to treat anxiety, mild depression and stress. You shouldn't have to refer that into a mental health service. So, it needs them to understand each other's problems and work together. So I would say there's huge attention on this. I can't sit here and tell you there's quick wins. No. Because it's a big problem. But there are several areas in the country where they've already managed to do the right thing.
Yeah. Obviously, we're kind of going into that actually now, because at our service we've established a small multidisciplinary mental health team, largely based on your recommendations from 2 years ago. And this team consists of qualified psychologists, trainee and assistant psychologists, and mental health nurses through the joint CGL NHS dual diagnosis project. So, how do you envision teams like this growing and evolving, both in Hull and across the nation? Well,
I think they must evolve according to the local need. I mean, it won't look the same in any two places, I don't think. Providing a good needs assessment has been done by the local authority before it commissions its service. That needs assessment ought to be able to inform what do you need in a service. How many psychologists do you need? What do you need in terms of mental health support? Or perhaps a mental health social worker. I mean, how complex are your cases? I think you can't just say that every area of the country is going to have the same need. I don't know the level of deprivation in Hull, for example, but I've just been in Liverpool, one of the most deprived cities in the country. There, you will really have to put in, there are going to be numerous problems that are related to trauma and mental health. And you probably are going to have to really put in, a really good supply of mental health and trauma support. So I think it's variable. And I think you learn as you go, because we've not been doing this properly before. And there's not been really good mental health support. I think one's got to learn how to work between the NHS and the provider if they're not the same organisation. And as I say, I think the people who work for the provider of treatment and recovery need to know how to treat anxiety, stress and depression. the NHS mental health services need to start to understand addiction and to be able to do some simple things there.
How do you perceive the role of mental health support in advancing the recovery agenda?
I don't think you can go through recovery, quite frankly. Well, very few people without mental health and trauma support. Maybe a few, but I think we know statistically for those people who are really very drug dependent, so particularly our heroin and crack cocaine users, I think near on 70+% of them have had a mental health or trauma. They may have had a terrible childhood. They may have been in and out of prison, all kinds of things. It is so much part of addiction. And if you want people to go on that journey of recovery, then for me, there's no question you need good communities of recovery. You don't need a professional doctor alone in a recovery unit. You need people who've been addicted. You need people who've done that journey. You need people who are now able to walk with someone while they go through it. They can do that much better than a clinical professional. So I'm very keen that we develop proper recovery communities. And then in that, there needs to be work. There needs to be the ability to get a job or to do something meaningful. And then there needs to be safe housing. I mean, one of the biggest challenges, especially, for example, in London, where housing is just so difficult to get. It's no use doing all the hard work of helping someone stop their drug of choice and then sending them back to live in a hostel with somebody who's shooting heroin. I mean, none of us could survive that. None of us.
We had a podcast participant where it's shut now. There was a big hostel in Hull where a lot of our homeless service users would often be situated. And when we talked to her on the podcast and was like, how do you know about achieving recovery? I could score drugs without even getting my feet wet because it was just rife within the hostel. So if you're someone who, like her in the situation she went, the reason why I found that story so inspiring was she got recovery in that hostel, but the difficulty she must have faced when, like say, she could, in the same way that we're in this hotel now, she could just scream across the room and that was it. Someone would come knocking within 2 minutes and there you go, there you've scored. So to do it under those circumstances is exceptional, but almost impossible for most as well.
And the work that's been going on with the Department of Housing is to try and understand, because we don't understand. You can't just say, well, I've got you a roof over your head. You need to understand what sort of housing is best required and needed for that particular person. Now, you might not always be able to get it, but you need to be able to understand what the journey requires. And there's no point putting in all this hard work if then you can't provide the wraparound that's going to enable the person to really come through recovery.
I had a story today, really inspiring, from a lad that really found his recovery through the help of religion. Now that's something that I found really interesting because it's not something that as a service that we can really push or say here's what to do, but talking to them, there's the project there that they have and the community that they've set up, that recovery community that they've set up, really inspiring of just being around like-minded people. But I do find it as an atheist myself, when I've heard these stories, there's that part of me that goes, but then there's the other part of me that goes, well, actually, if that's what works, that's incredible.
Doesn't matter. If that's what works.
Yeah, absolutely.
What works for you may not work
for other people, yeah. What opportunities do you think exist for developing specialised roles such as social workers to better meet the unique needs of individuals in recovery and with addiction issues?
I think if you're going to develop the role of a social worker, first of all, we have one role that's been developed, not for addiction, but would be very useful for addiction. There is now a training to become a mental health social worker. That is now a government Department of Health funded training program. It's called Think Ahead. So anyone now can add mental health. And one of the things I'm trying to secure at the moment is that program can be expanded so that we can train a mental health addiction social worker. Because if you think about it, those three things are things that any person who is drug dependent might need. So the mental health component, some knowledge of addiction, and a social worker.
Yeah.
So we're in discussion with the Department of Health whether or not that program, which is delivered, the academic component is delivered by Middlesex University, and then the clinical training is in our mental health trusts. Whether we can just enlarge that. So I think people certainly centrally are discussing, how do you utilise other roles? How do you utilise the role of a pharmacist? And you could do a mental health addiction nurse, I think.
Yeah.
Because you need people who've got a variety of skills, and these are. It's not difficult to envisage
No,
this.
absolutely not. And I mean, we've got in our team, I know we've got a mental health nurse, for instance, that's got a really good addiction background, but that isn't part of her role as such. That's from a previous role that she has an understanding of. So it's really beneficial that she has that experience, but really on paper, that wasn't required for her to do that role. So yeah, I think that sort of amalgamation of those different things is necessary.
In these cases, you could train on the job, could you not?
Yes, absolutely.
I mean, a mental health nurse, if they go into a good treatment and recovery situation, surely can learn on the job.
Absolutely. Trauma-informed care is gaining significant attention and forms the foundation of the work of the Renew mental health team and many other teams in the city. There are ambitions for Hull to become a trauma-informed city. What are your thoughts on trauma-informed care and how it impacts the communities we serve?
Oh, I think it's crucial. I mean, so many people who tell me their story tell me about trauma. And even if they don't give you all the details, that they've had perhaps a very difficult childhood, perhaps they've grown up in a house where their parents have been addicted or where there's been domestic violence. And the trauma doesn't always have to be that sort of trauma. I still remember one young lady who said to me, you might think that my upbringing was in a good middle-class family. And, I didn't have any trauma. But her parents worked abroad and she was sent away to boarding school from very young. And she hated it. She was taking heroin by the age of 15. And it was she said it took her a long while to recognise and then deal with what for her was her trauma. It wasn't the trauma of being physically or sexually abused, but it was trauma.
Yeah.
And so I think having people who are trained to help people deal with this trauma is just crucial, not just a drug addiction.
No. I mean, I've had some interesting conversations around trauma through this podcast, and one of the things that I found really interesting was people start taking drugs because of the trauma.
Of course.
But once they're at that point of, okay, I'm in addiction, they experience something called like continuous trauma, where they're putting themselves in position of sex working, for instance, and by being a sex worker to fund their already existing drug habit, they're now experiencing sexual assault and rape, and then that is further adding to the trauma and to the trauma, and then it just keeps going on. Yeah. So it's not necessarily just a root cause of trauma that started the addiction, is you've got to unpick the initial trauma, then all the trauma that's followed on while they've been using substances as well.
And that probably would be, the trauma might well be augmented if you were sent to prison.
Absolutely, yeah. Prison itself can be traumatic.
Do you know? Yeah. I mean, you can think of all kinds of things whereby it's additional trauma. So you've got multiple episodes.
Yeah, absolutely.
And I think that again is a journey. So I think trauma-informed care is invaluable.
Yeah, it's been really interesting, and I manage the volunteers in our service, and all those that have taken on the trauma-informed training have found that so beneficial, not just for their practice, but looking at their own behaviours as well. Like they said, it was weird, really unpicking their own past lives and, that's why I react in this way in that situation. That's why I don't enjoy working with someone who has this status and authority. And there's all these sort of things that are really interesting to unpick with it. Despite 2 decades of evidence-based and expert-led guidance on supporting individuals with co-occurring conditions, i.e. mental health and substance use disorders, change within mental health systems and the culture of some mental health services seems slow to progress and perhaps even resistant to change. What do you believe needs to be done to accelerate the process?
Well, I think I answered that right at the beginning, really, because I think you've just got to keep talking about it. Every time somebody says to me they need to be treated separately, I stop them and say, stop. This is not like that. Addiction is so related to and connected to mental health and trauma. You cannot. So, you first of all got to change the language. You've got to get the mental health professionals to think differently about this. And we need the support of the Royal College of Psychiatrists. Yeah. Because they could be a great advocate for us in changing this language, in changing the attitude of people. We need the psychologists to change their attitude. So culture isn't easy to change. And then we need the practical steps that allow 2 services to come much more closely together. And as I say, in the very best of all worlds, be co-commissioned.
Absolutely. I do think there's, I think I spoke to you when we did the first podcast, but I remember years ago the difficulties of mental health, and in the sense of we'd work with an individual, mental health problems, substance use problems, we'd refer them to mental health because they need mental health support, and they would baton back to us and say, no, the reason why they have mental health is because they've got addiction issues and because they're taking substances. That doesn't happen as much now. We actually have, I don't think it happens at all now. We actually have really good pathways with Mind, the Hull and East Yorkshire service, and obviously, as I've mentioned already, the multidisciplinary team of clinical psychologists that we've created in terms of a real mental health team. So there's definitely improvements, but I completely understand what you're saying about a co-commission service for mental health and substance misuse.
That is
all under one roof.
That is ideal, but I think, it may not be possible everywhere, but surely the communication and surely each of the mental health sort of providers and the addiction providers, the people who work for them should widen their minds and learn how to deal with each other's challenges to a certain degree. Of course, I don't expect an addiction provider to deal with schizophrenia. That would be ridiculous.
Yeah, of course, yeah.
And therefore you need a proper referral into a proper mental health service. But I do expect people working in addiction in the future to be able to deal with a person's mild anxiety, mild depression, or stress. That is not difficult. I trained as a rheumatologist.
I remember you saying.
I didn't refer people with hypertension that was ordinary, straightforward hypertension, or somebody with irritable bowel. I didn't bother the cardiologist and the gastroenterologist. They're too busy. And I'm a doctor, and I have been trained. So I'm perfectly capable of treating hypertension or treating irritable bowel in its mild, ordinary form. So that's what I mean by people just stretching their minds, realizing they just have to be a little bit more elastic and flexible in what they're prepared to do.
So what role do you see service users playing in the development of mental health services within drug and alcohol treatment? One of the big things at the moment is the buzzword that I'm hearing a lot right now is co-production, and obviously having service users involved from the beginning up to the end and stuff like that. So what do you think of that?
Well, I wrote very clearly in my review that I saw service users and people who'd been on this journey as a crucial part of recovery. Now, I think that could either be that they are part of the treatment and recovery service, so they are related to the treatment and recovery service, and part of that whole service. Or it could be that they're the LEROs, that they're the lived experience groups, and they then won't be necessarily the people who are obviously doing the more clinical treatment. And I don't think that matters. I think those two different groupings need to learn to work with each other. Yeah. But I do think, and the department and OHID has just published its framework of recovery. So it's just... it's a reasonably lengthy document. It really defines what is recovery and the different sorts, if you like, of recovery, gives you the evidence base. Why is recovery important? Where's the evidence that shows it makes any difference at all? And then how any local area should develop its recovery services, and gives a variety of ways of doing this. So again, I don't think there's any right or wrong, but as I said in my review, do not think you should misuse people who've been drug dependent and are now wanting to work in the service by treating them as cheap labour. That doesn't really impress me at all. Of course. And I think there also should be the opportunity for education and training and a framework in which these recovery services will be delivered, just like we have for the more clinical services. So I think the contribution that the centre's just made with this document, which is really for commissioners and providers of services, lays out some quite sensible rules, and to really encourage people to work together. So I think there's a big learning curve for commissioners and indeed for providers to work well with people who have been service users.
Absolutely. I've mentioned it to you before, but I'm the volunteer lead for our service. So service user involvement, that's my bag sort of thing, getting people involved. And I've always had frustrations, and I've heard those frustrations in the past around it always feeling tokenistic and not really needed, and always coming to me at an opportune moment where, we've got a report to fill in. But the one thing I found interesting recently was looking at the way CQC registered sites are going to be inspected, and how much more of an emphasis on service user involvement and service user voice there's going to be than any other time. And I mean, we've continued to try and push our connection with Care Opinion and the subscription that we've got there, so service users can feed back, and that feedback is public, it's in the public domain, people can see it. And I think that in itself encourages a service to take on the feedback that they're given much more promptly, as opposed to a service user just saying in passing, I think you should do this, I think great, off you go, sort of thing. So we're taking on that information in a different way to how we would previously, but there's still a way to go. I think the CQC thing will change things, but there definitely needs to be more of an emphasis on service user voice, because at the end of the day, they're the majority. And as our service manager will always say, it's their service. We just have the pleasure of working here with them. So we have to listen to them at every step of the way.
And they know what works.
Absolutely, yeah.
I mean,
exactly, yeah. They're on the receiving end of it. They know what works. They know what won't work.
And they know what won't work.
Absolutely, and I think this is it. Sometimes is going back to that incentivising appointments and coming in. I don't think that would work, and I don't think they've not said anything about it. It's just an idea that was thrown out there for them to be involved. But as you said, I think the incentive is good quality treatment and helping them with their problems, and it not feeling tokenistic or like a long drawn out process with 1,000 questions at the point of triage. Just human stories. Professor Dame Carol Black, the UK Recovery Walk is an annual gathering, which obviously you've joined us for this weekend. So uniting individuals in recovery from addiction, their families, friends, supporters and its allies. Its primary aims are to combat the stigma surrounding addiction, increase awareness about the potential for recovery and foster a sense of community, which we've spoken about today. We're excited to share that you'll be present at this event in Hull tomorrow. Can you share what a significant event like the UK Recovery Walk could hold for you? Obviously, this is your first one. You've done so much work around this. What's it like for you coming and being part of this?
Well, it's wonderful to actually walk with people who have actually walked the journey of recovery, which I have not done, and to really be and see people who have made it through that journey. I mean, not everybody manages it, but and maybe some of them walking tomorrow are still very much on that journey. But I always believe when you do any work, you can read all the books and reports and papers. Of course, you should look absolutely for the evidence, but in the end, actually, you need to go and talk to the people and be with the people who've have this challenge. And that's true. I mean, I'm a medic, and you practice medicine with human beings. You learn the if you like, the theory of medicine and all the pathology and the physiology. But in the end, I was a hospital doctor. You do it with your patient. You don't do it in some theoretical, blank space. And you learned very much that you got the best result if you and the patient work together.
Yes.
And so for me, it's been part of a community of recovery.
And you went to the Recovery Games last week as well.
I did.
And tell me, we spoke about it briefly in the lobby, but tell me about that. Like, what brought you to the Recovery Games this year?
Well, I was invited.
Oh, no. Just on an invite, I thought I'd go. Well, what was it like then? Because was that one of the first events that you've been around such a positive or high amount of recovery?
Yeah, I mean, it was fantastic because there were all these challenges. Some of, they were just so much fun. There was a climbing wall. They had and a lot of them were inflatable things, as you know. So a lot of water sport when they were racing each other around the water sports. It was just so much fun to see the competition. A lot of music, prizes to be given away.
We did it a few years ago, and again, it was probably in my entire time working in drug and alcohol treatment, probably one of my favourite days where I came out of there just thinking, I love my job. Such a positive community to be a part of, and it's infectious as well. I always say this, the camaraderie that comes with people, like, especially in fellowship meetings like the 12 steps and the way they hug and embrace each other. I was like, everyone needs community, but it's for all the trauma and negativity that these people have experienced, in their lives, how nice it is to come together and experience such a positive atmosphere.
And what was also very nice was I met some of the families.
Yes.
Because you often just you don't
often get to talk to the families.
You don't get to talk to the families. You often you may be fortunate enough to talk to the people who are doing the journey, but not necessarily their families.
And we always say no one goes into addiction alone, so it's nice to hear. And the pride that people will have. We had a guy, he's working with us now, but he went through addiction and speaking to his daughter, and she was just saying how nice it is to have her dad back. Because through addiction, he wasn't there. But no, Professor Dame Carol Black, once again, thank you so much for coming on the Believe in People podcast. And if you've enjoyed this episode of the Believe in People podcast, then please check out our other episodes and hit that subscribe button. You can also find clips, outtakes, and extras from this series on Facebook, Instagram, Twitter, and YouTube at CGL Hull. That's at CGLHULL. We're on Apple Music, Spotify, Google, and YouTube Music, so please like and subscribe to be notified about new episodes. You can also search for Believe in People podcast on your favourite listening device, and if you can leave us a review, that will really help us in getting our message out there and rising up the daily podcast charts.